This is University of Michigan. We call this the Taj Mahal. That's a new CS Smart Children's Hospital. And this is the whole campus. And I work for the VA, too, the Ann Arbor Healthcare Health System. You can compare the sizes. But, I'm here to present. I don't have any disclosures. My images, my slides are camera shy. So it's just that, respect to the patient images, I know you would not be able to copy those and do anything with it, but still. And English is not my first language. If somebody gets turned on by my R's, I'm sorry. Okay, so this is from, we published this paper with Sean, who's here, who did a presentation earlier, on teledermoscopy in teledermatology. I need to thank Gloria and Arjun. Gloria has graduated and is now assistant professor at Stanford, and Arjun is in third year medical school. So it was a nice collaboration of all the four of us, and the burden was on this guy who did all the work. I'm just presenting it. So what we did was after 2005, all the publications which had dermoscopy in teledermatology, we looked at it and we made a kind of a summary for you guys. So I'm not going to present all the 25 publications which we have reviewed, but I'm going to give you some summary of those. So we all know at the end of the day, the dermoscopy does make a difference in your diagnosis. It improved the diagnosis rate from 84% to 97%, which is quite significant. And in another study, they showed that when they compared their images with the current images, they found that their referral rate had increased. So it means to say they referred the patients with dermoscopy images directly to surgery, to dermatosurgery for excision or any kind of further work. It also improved significantly though it improved the primary diagnostic accuracy, some studies did show that it didn't statistically significantly improve aggregated diagnostic accuracy. That means to say, if your clinical diagnosis was A, B, and C, the dermoscopy diagnosis could have been C, A, and B. So it didn't make much of a difference. And they also showed that adding dermoscopy evaluations increased your concordance rates, but it was not, again, statistically significant. These were some of the literature which is out there. So we all know that we take care of patients, right? Statistically significant is one thing, but there are times when it makes a huge difference. And how many of you use dermoscopy in your teledermatology practice? Awesome. So you'll all be put to test in the next 5 minutes. So these are the clinical images. I'm going to show how many of you think what it is. It's going to be completely interactive. BCC, that's a great answer. Neurofibroma. Dermatofibroma, great answer. Like keratosis? Sure, if there's some scaling, pinkness, yeah. Traumatized nevus, awesome. Right? We're going to go to the next one. What do you guys think about this? BCC. Bowens. Answer could be blurry image. Yes. I wanted that. Yeah, what else? What do you think about this? BCC, wow, you have dermoscopy eyes. That's awesome. But nothing, scaling, subcare, subderm, they're all good diagnoses for this image, correct? Sézary syndrome, erythroderma, psoriasis, parapsoriasis, CTCL, all of them are good diagnoses. BCC, Bowens. Yeah, you guys are banking on this, right? Good. Nobody's commenting on this. If I said that was a 60-year-old man who had it for 3 years and he picked it off, that's what you had. Excellent, yeah, irritated septic care. Nothing? I like this. This is Alistair Cook getting stung by Mahendra Dhoni. Yeah, the beauty of me training in India and then going to Michigan is this. I know some cricket too, so I used to play cricket. And this is called a surrender Cobra sign. Oh my God, I don't know what to do now. Right? All of you who did answer, there were answers there. But everybody wanted to ask one question. Show me the dermoscopy image. Right? Let's go to this. This was a 70-year-old man who had this spot, which was picked up by his primary care, which was there for 6 years. Didn't notice this. His wife noticed it. They took a picture. So this is the last session of dermoscopy in teledermatology. Dermoscopy. Amelanotic melanoma. That was what it was. So the person who biopsied it even didn't know that it was an amelanotic melanoma. That's because he shaved it in such a way that people thought it was a superficial spreading melanoma. But the bottom line is you caught a melanoma. And this made the difference, right? What was this? Dermoscopy. So I want you guys to let me know that you need dermoscopy images. So this is an ulcer with multiple polymorphous vessels and white lines, all fit for melanoma. This was another melanoma. And this was nothing, right? Like we call this, maybe white scale. Yeah? This was actually BCC. You can see branching vessels, maple leaf-like structures, white lines, slam dunk BCC. If you've done dermoscopy, you will pick this up right away. This was interesting. This guy was a 70-year-old man who was homeless. Look at this. Look at that. You didn't even have to see burrows here. These were entrenched in the scales. These guys, see these guys? This is called as delta sign, right? Norwegian scabies. I didn't show you this. Yeah? So dermoscopy does make a difference, right? This one, as I said, this was the story. That was exactly the story what I got. But if I didn't have dermoscopy, I would have missed the BCC, which was on the top. Dermoscopy makes a difference. Is it statistically significant? No, it's patient significant. That's important, right? This was actually Lentigo Maligna. So it's an eye-opener. This is amazing. People today have talked about dermoscopy in lesions. I want people to do dermoscopy in rashes. It's very important. And why it is important? You can diagnose lichen planus, discoid lupus erythematosus, follicular tropic MF, a lot of them. Do it. It's fun, and your diagnostic accuracy improves. So the next subsequent slides, I'm going to show you a list of photodermatoscopy equipments which are present. And this is, who this guy is? This is Billy Borden. He's from New Zealand. He's a world famous umpire, and he does different styles when somebody hits a 6. So, yeah, these are the list of equipment for teledermoscopy. It's a huge list. We don't rank them anywhere. We don't rate them. This is just the list. And like this is the basic list which you start. It has a what we call as a dermoscopy attachment. This is more like this is what we've mostly used. The only issue with this is when you have every time you take an image, you have to take out the memory card and upload it into the computer, which can be sometimes an issue because if somebody loses that memory card, it can be a HIPAA compliant issue. So using mobile devices which are Bluetooth compatible actually helps transferring these images. Like, I don't know how many of you know Epic, which has a tool called as Canto or Haiku, which are mobile apps, which helps you upload the images directly into the medical charts without being stored on the phone. So that's one way of getting rid of these issues. If you can get fancy, all these companies make some amazing SLR-associated images, dermoscopy attached cameras. And of course, you have so many of them, which are like the iPad attachments, the iPhone attachments, the Android attachments. And if somebody wants to have like an office, it could be a full total dermoscopy system, which is kind of fancy, and it's also kind of expensive too. So when we were going through literature, we didn't come across anybody telling how to teach to take these images in a certain way. And this is what we use at the VA to teach our nurses. So we tell them that the dermoscopy image should follow a macro shot of the lesion. If you've taken a macro shot of the lesion, it has to be immediately followed by a dermoscopy image. That way, the reader does not have, like sometimes it has happened that you have 10 macro images followed by 10 dermoscopy images, and the reader would not know which one is which. So emphasize that your macro shot should be followed by a dermoscopy image. And make sure the dermoscopy attachment is turned on. A lot of people don't turn it on. And suddenly what you see is just a blurry, dark image of dermoscopy. So the way I teach it is, the reason why I tell them not to do a non-contact first is because when you do a contact, it blanches the blood vessels. And blood vessels are such an important part when you're diagnosing pink lesions, whether it be basal cell, squamous cell, or melanomas. Blood vessels is such an important thing. And when they blanch it out, it's a big issue. But I want to do contact is just because you can see those white lines or white crystalline structures, which are such an important part in diagnosing, again, basal cells or melanoma. So if you're using a non-polarized setting, you actually use an ultrasound gel or an alcohol gel prior to the contact with the lesion. This is what I recommend for the rash. I know people have just spoke about lesions, talking about the rash. So include the normal adjacent skin to the rash. Again, the dermoscopy image should follow a macro shot and include the normal adjacent skin to the rash. And the proportion to the normal to the abnormal, which is normal is your normal skin and abnormal is the rash, around 25 to 75%. So 25% is your normal skin, 75% the abnormal rash. And always include complementary views. Means like if you've taken a picture of the chest, its elbows, take the pictures of the knees, foot, hands, bottom of your hand, palms, soles. And when you think that there is a compromise in epidermis, some of the manufacturers make disposable caps, which you can put it on and then take the images and throw it away. The limitations of teledermoscopy is the dermoscopy itself. It's a 2D image. Means whether you are going to see it live or you're going to take a look at the image. It's a 2D image. It's not going to change. So there is no limitation here. So the highest accuracy in all the studies showed that the dermatologists have to be dermoscopy experts. When they're experts, then their diagnostic concordance rate is high. When there are studies showing that initially, if a naive person starts it up, he would call everything a melanoma or a malignant lesion. There is I agree with this a lot. there is a high inter-observer reliability issues with teledermoscopy images. Means it all depends on the definition. Means there were studies which showed that there was a high concordance rate in the dermatology readers who were from Australia or Southern Hemisphere, whereas when you included one person from the Northern Hemisphere, the whole thing changed. The way we call dysplastic nevus, severely dysplastic nevi to melanoma in situ to melanoma is such a diverse thing. Again, high quality images, and high quality images. That makes, that was mentioned in almost all of these studies. So the recap, vast majority of studies showed that improved diagnostic accuracy of skin lesions was basically due to the dermatologist dermoscopy image reading experience and the quality of images provided. In future, if we can include a handheld device which has confocal imaging, that would actually make a difference because you're looking at a cellular level. And integration of different colors into dermoscopy, maybe include Woods lamp frequency LEDs into dermatoscope, may help define rashes. And as I said, the mobile applications may improve the HIPAA compliance because they're, you could easily transfer the images and they're not stored on your phone or your mobile devices. They go directly into that chart. It's the last slide. What do you guys think about this now? It is SIPCARE. So, he's an expert, they're experts. So experts can call it. But for me, I had to biopsy it. So it all depends on your experience. So dermoscopy training is such an important thing when you're doing teledermatology, if you're using dermoscopy as one of the issues. Thank you.